Hello, I'm hematologist-oncologist Dr. Tony Talebi. Today we're going to discuss rectal cancer. I have the pleasure of being with Dr. Lauren Sands, Professor of Surgery, and actually the Chief of Colorectal Surgery at the University of Miami. Thank you for being here.
Thank you for having me.
Dr. Sands, what is rectal cancer?
So rectal cancer is really just cancer of the rectum, and the rectum represents the lowest portion of the intestinal tract. So it's attached to the colon, but it's the lower portion. It basically constitutes the last 7 or 8 inches or so of the intestinal tract. And these cancers that can develop anywhere within that particular area.
So why do these cancers develop at all?
Well, that's a good question. Nobody really knows what causes colorectal cancer. We do believe that there's a lot of factors involved in it. We believe that there's a genetic predisposition to getting this. We do know that first-degree relatives who have it have probably some higher link of familial traits of getting colorectal cancer. Some people have stipulated that maybe diet has a factor in this, although it's never been actually proven why people get that, but it's been one of those things that's been out there.
So look, I think if you could do it specifically, patients always ask us, would you please demarcate anal cancer versus rectal versus colon?
Yeah, so anal cancer is slightly different. The difference of anal cancer as opposed to rectal cancer would be that it's really based on the cell type that exists. So anal cancer, because the anus is lined by skin that's like all over your body, you get different types of cancers arising in the anal canal as opposed to the rectum. The rectum is lined by mucosa, or a mucosal lining, which is what the colon is lined with, and therefore you get these glandular-based cancers, which are known as adenocarcinoma. So the typical colorectal cancer is an adenocarcinoma, and the typical anal cancer is basically a skin cancer. It's an epidermoid cancer. So the cell type is what really distinguishes whether this is a colorectal cancer versus an anal cancer.
I see. Okay. And what about the demarcation between rectal and colon? Do you measure a certain amount?
Well, it has to do really with the distance that it is up the intestinal tract. The rectum is really, as I mentioned, the lowest portion of the intestinal tract. As far as where it actually starts and where it ends, it's a little bit debatable, but the rectum is really divided into 3 levels. There's the upper portion of the rectum, which is really a continuation of the colon itself, and then there's a lower and middle portion of the rectum, and those lower and middle portions of the rectum are a little different because we have direct access to that. On rectal examination, we can typically feel those tumors, and we can do certain maneuvers of those particular tumors that we can't do in the colon because they're higher up and we don't have the accessibility to reach those particular cancers.
I see. What about, are there any genetic implications? Should family members seek genetic counseling if your patient's been diagnosed with rectal cancer?
Yeah, so if what we basically tell family members is that if there is a strong predilection or if someone in the family has colorectal cancer, a first-degree relative, we generally recommend screening the other family members at least 10 years before the youngest relative would have it. Okay. Now, because colorectal cancer is a disease of the 6th and 7th decade of life, this would put most people at an age of about 50 or so to start screening, which is what normal screening recommendation is now for colorectal cancer. We start screening at the age of 50, doing routine colonoscopy. However, what I typically recommend is that if there is a family member in their 60s or 70s who has colorectal cancer, we would start screening that family members earlier, so we would recommend dropping that age of 50 down to 40. And if a family member had colorectal cancer at the age of 30, let's say, we would drop the age down 10 years below that age to the age of 20 before we start screening for colorectal cancer.
You alluded to this before, but as the obesity epidemic is getting worse, so is the incidence of colorectal cancer. What are your thoughts on that?
We see more aggressive cancers probably in younger people than we used to. I don't know that there's any stronger predilection of getting colorectal cancer because patients are obese. There's really been no correlation to that. In fact, actually, when you look at the data on this, the actual incidence of colorectal cancer is actually declining slightly in this country, probably due to screening colonoscopy. We're so aggressive now about sending patients for screening colonoscopy. The rationale behind all of that is that if you screen patients appropriately, you find polyps, which is what colorectal cancer comes from, and if we remove polyps, we'll remove them before they ever get colorectal cancer, and it's really a completely preventable disease, which is really the best news about colorectal cancer, is that it is completely preventable, and nobody ever has to get it as long as you just do the standard screening recommendations that we suggest for this problem.
When would you recommend screening for a colonoscopy or a sigmoidoscopy?
Yeah, so colonoscopy should start at the age of 50, as I mentioned, unless there's a family member, in which case we move the age down appropriately based on the family member who had colorectal cancer. Okay,
so we'll get to the treatment specifically later, but generally speaking, let's say someone's had a colonoscopy and a mass is found in the rectum. What happens next for that patient?
So typically what we do is we would see these patients in our office. Actually, we get there's tissue confirmation, the biopsy is taken on the colonoscopy. The biopsy will confirm the presence of the malignancy. Once we know that there is a malignancy there, we generally do several tests to make sure the disease hasn't spread anywhere else. We'll get a CAT scan typically of the chest, the abdomen, and the pelvis, because this is where the disease typically would spread to. If it does spread, make sure they don't have metastatic disease. And then after that's done, we typically do a rectal ultrasound, which is an office-based procedure that's done by a colorectal surgeon. And basically, this test is it's a non-invasive test that gives us a lot of information about the tumors themselves. It's slightly uncomfortable to do, but it's not painful by any means. We don't do it even with sedation. That's how simple a test it is. The patients come to our office, and we do a rigid sigmoidoscopy where we look up to see the actual height of the tumor, to see how high up it is from the anal verge, from the opening of where the stool comes out. And then we take a probe and put it inside, and the probe has a little transducer on the end of it that spins around, and it sends sound waves out through the rectal wall. And that ultrasound will give us basically 2 bits of information that are important to us. Number one, it tells us how deeply that tumor penetrates through the wall of the bowel. That's important for us for staging purposes for the cancer. And it also tells us whether or not there are lymph nodes around the rectum that could be potentially involved with rectal cancer, because rectal cancer can spread to local lymph nodes around that area. So the ultrasound is done in order to look for those 2 things, and those 2 things help stage these patients for colorectal cancer.
I see. I think we should just continue talking about it. So when do you decide whether someone should have surgery up front or whether they need another treatment?
So based on the staging up front, so based on what information we get from the staging, the more advanced cancers, the tumors that are higher stage tumors, would benefit from chemotherapy and radiation therapy before surgery. We're all pretty much in agreement at this point across the board that neoadjuvant therapy or preoperative chemoradiation therapy is extremely beneficial for these patients. So basically, any tumor that's more advanced would be a candidate for that. If the tumor is less advanced, we generally proceed right to surgery. And there are different options available surgically that we'll talk about today. But typically, if we think these tumors are advanced, we believe that there's benefit in giving these patients chemoradiation therapy up front. The benefit of the chemoradiation therapy will shrink the tumor, it will make it smaller, it will make the operation easier for the surgeon, which is going to be easier, of course, in translation for the patient. Sometimes the chemotherapy and radiation up front given is so effective that the tumor burns out completely as if there was no tumor left at all. And that's very good news. We're happy about that when that happens because the outcomes are so good. But sometimes the tumor there is some tumor remaining, and then it just makes the tumor a little bit smaller and a little bit easier to resect these particular tumors.
All right, so let's just take a step back. Sometimes an MRI is obtained of that area. Do you recommend that one? What is the reason for that?
You know, we don't really adhere to MRIs here at this institution. There are some surgeons using them. I haven't found them very helpful, particularly because as a colorectal surgeon, I'm very well trained in reading CT scans and ultrasound, and I get all the information I need out of those. There have been some people who advocate doing MRIs. There's been a lot of literature to suggest the benefit of MRI. I personally don't read MRIs. It's harder for me to interpret them, and I have to rely on someone else's interpretation of them. So I prefer to have my own interpretation of these studies, which I can easily read as far as a rectal ultrasound and the CT scan. So we don't routinely get MRIs of the pelvis. If we feel there's a reason to, if some of the imaging is not clear, we would then get an MRI of the pelvis. But normally we don't obtain an MRI of the pelvis for these particular patients.
You also mentioned higher stage. Would you please simplify for our patients, what is the staging system and what are the different stages?
So the staging system for colorectal cancer is based on 3 factors, basically. One of them is called the T, which stands for tumor. The next one is N, which stands for lymph nodes, and the last one is M, which stands for metastases. So basically, those are the 3 things we look for in terms of staging these cancers. So the tumor is based on the depth of invasion. So we particularly are interested in how deeply that tumor penetrates the wall of the intestine, which is very nicely seen on a rectal ultrasound. The next thing that we look for are the lymph node involvement, which is also nicely seen on a rectal ultrasound. We can see these big dark spots outside the rectal wall, which suggest positive lymph node involvement. We even have the ability now of even obtaining biopsies of those lymph nodes with some of the fancier ultrasound imaging that we do in our office here, which is really very nice. We use 3D imaging of the rectum in order to see this now, which makes it very clear for us. And the last thing we do is we look for metastatic disease. Metastatic disease is looked for on the CAT scan of the chest, abdomen, and pelvis. And basically, anybody who has metastatic disease is clearly in the most advanced stage, or it's stage 4 cancer. People who don't have metastatic disease are in lower stages of disease, so either 1, 2, or 3, and that will depend then on how deeply the tumor penetrates the wall of the bowel and whether or not lymph nodes are involved. If there's lymph node involvement, there'll be at least a stage 3, and anybody with a stage 3 cancer is a candidate for chemoradiation therapy, and many patients with a stage 2 cancer will also receive the preoperative chemoradiation therapy, depending on how deeply the tumor penetrates the wall. So the more deeply the tumor penetrates the wall, the higher stage of the cancer.
Okay, let's take the first scenario where it's an early stage cancer and you do want to operate. What do you tell that patient in terms of pre-op, during surgery, and after surgery?
So if they have an earlier stage cancer, there's really a few options available to the patient. The standard option that we most likely recommend is we do what's called a low anterior resection, or a restorative proctectomy, we call it. A lot of these operations now are done laparoscopically. We do a lot of these laparoscopically now. There may be certain situations where they're not really candidates for laparoscopic surgery, but most of the time we will attempt laparoscopic surgery for these patients. And then we basically will remove the rectum, and then we make every attempt to restore the continuity of the bowel. We bring the bowel from higher up and we pull it down to the lower portion of the intestinal tract, to the anal canal, and we sew the bowel back together. And a lot of times, because these hookups, these anastomoses as we call them, or the hookups, are so low down, we typically like to divert these patients with a temporary stoma, which is an ileostomy, or a bag that comes up to the skin that evacuates the stool onto the skin into an appliance. We do that usually for about a 3-month period. The reason we actually do that is because we believe that these low hookups have a higher chance of leakage. When we put these two pieces of the bowel back together like this, we have to make sure they heal well. The areas can separate sometimes. If they do, these patients can get very, very ill. So typically we will divert the stool for a temporizing measure for about 3 months before we reverse the diversion and then put them back together. If the tumor is really an early stage tumor, or even a benign lesion, let's say a benign polyp of the rectum that had to be removed, we can take that out transanally. We actually go through the anus and actually carve out these tumors through the anus. The advantage of that is it's a much simpler operation for the patient to undergo. The downside to that is we never get lymph node sampling with that, so we don't really know the full stage of that cancer ever until the final pathology is in the pathologist's office, where the whole rectum would be removed. So if you do a local excision of this, you'll never really get the full staging of this cancer. You'll only have it based on the preoperative imaging that you did, which is the ultrasound and the CT scan, and those are not 100% accurate, as opposed to the pathology read, which would be 100% accurate.
So how often do you end up doing just that very local excision as opposed to?
Local excision has been kind of, was a very popular procedure at one point. We've now kind of moved away from it in most circumstances now, because some of the data suggests that doing local excision may not be as beneficial for the patients long term. Some of the statistics on local excision have shown that the recurrence rate may be higher, that when the tumors do come back, if they do come back, they usually come back at a more advanced stage, and then these patients may not be curable. So basically you had a patient that you thought had early stage disease, you do a local excision on them, the disease comes back, and now they may die of the disease. That would be really catastrophic for us as surgeons, when you may have done a more radical operation initially and cured them of the disease, which was an early stage disease. So a lot of us have gotten away from the local excision. I still think there is a role for it. It certainly is a role for the benign polyp of the rectum, absolutely. And it certainly is a role for excising these tumors locally if the patient has multiple comorbidities or many other medical problems that they can't withstand the major operation. These would be good options for those particular patients. Otherwise, for the younger, healthier patient, we tend to recommend a more radical resection for these patients.
What about the possibility of either bladder or sexual dysfunction following surgery?
That risk ranges somewhere between 8 to 10%, but if you remember, we're dealing with usually an older population in general, and many of the males that we typically operate on who have this already have some degree of sexual dysfunction to start off with, so that doesn't really help the situation. But typically we quote about an 8 to 10% incidence is what the quoted number is in the literature. Our numbers are probably lower than that here at this institution, although we haven't looked at them recently.
When can the patient get back to work if they are working?
So typically this whole ordeal of major surgery would typically have these patients out of work for the time of the surgery, which typically, if we do these laparoscopically, the patients are in the hospital somewhere between 3 to 5 days after the surgery. Then they're recovering at home for another week or two. So they need generally about 2 to 3 weeks out of work in order to have all this work done. And then they're usually able to go back to work, but we usually put them on a slightly restricted regimen of no heavy lifting or heavy exercise or anything like that, just because we don't want them to get any hernias in the incision sites.
I see.
But after that, they'll be back to full work in probably about 4 to 5 weeks for sure.
I see. Well, obviously, unfortunately, not everyone has the opportunity to be operated by a chief of surgery at a university hospital. What is this concept of mesorectal excision? Why is that so important? Why do they need to know that their surgeon will do that?
So one of the most important things is that this operation is done oncologically sound. So the rectum has blood supply to it called the mesorectum, which is the blood supply to the rectum. And when you do these operations, the most important thing is to remove the entire blood supply to the rectum, not just the rectum itself. The reason you want to do that is because it's in that blood supply to the rectum lie the lymph nodes and all the other areas that could potentially drain the tumor basin. So there could be disease sitting in that mesorectum. So the most important thing as a surgeon is you want to do a total mesorectal excision. You want to remove that entire mesorectum, remove it with the rectum itself, so that way all the localized disease is removed, and that will have the patient will have the best chance at a reduced recurrence rate of the cancer if that operation is done that way.
So is that a question that patients should be asking their surgeon?
Well, the surgeons should hopefully know to do that. You know, I strongly recommend that for rectal cancer that the patients seek out a colorectal surgeon to treat that disease, because they are specialists in dealing with that particular problem, and they're well equipped and they know to do that. They don't have to be told to do that. Many general surgeons probably know it as well, but they probably don't do nearly as much of that operation in that particular area as a colorectal surgeon would do. And it's like anything in life, the more you do of one particular thing, the better at it you are. I don't do any gallbladder surgery, any appendicitis anymore, but I just concentrate my efforts on colon, rectum, and anal surgery, and therefore you get much better at doing those particular things when you concentrate your practice in them.
I see. What about the concept of sphincter preservation? That's so important. How does that play into your surgery?
You know, we always make an attempt at sphincter preservation. It's extremely important. The patients don't want to live their lives with a permanent colostomy or a permanent stoma. We make every attempt at our institution to do that. I think giving these patients neoadjuvant therapy may help sphincter preservation as well by shrinking the tumor before the surgery and making it more amenable to surgery. You know, but if the tumor, really the most important thing about this and what determines sphincter preservation is location. And it's like everything in life, the real estate agents will tell you location, location, location. And we'll say the same thing about rectal cancer. Location is extremely important. The lower the tumor is, the harder the surgery, the greater the likelihood of colostomy. The higher the tumor, the lower the likelihood of colostomy. So that's really what it basically boils down to, is the location of the tumor and whether it's attached to other structures in the area that require more of a radical operation and more of a you know, whether or not you can get below the tumor adequately in order to restore these patients.
What if the scenario where the patient has advanced tumor in which they need chemoradiation but they're bleeding? What happens in that scenario?
So if they have a more advanced cancer and they're just bleeding from it, there are some other palliative measures that we can take. We can recommend. We can just divert these patients with a colostomy and not remove the actual tumor. Sometimes we can use electrocautery just to burn off the areas that are bleeding. There's been argon plasma coagulators that have been used now in order to stop the bleeding sites of these things. But these are more palliative measures rather than curative measures for rectal cancer.
I see. Okay, now there's another surgery called an APR. What is that, and when would you utilize that?
So an APR is an abdominal perineal resection. It removes the entire rectum and it leaves patients with a permanent colostomy. So it does a total mesorectal excision just like we do for the restorative procedures, which is the sphincter preserving procedures. But the APR would remove the entire rectum and give them a permanent colostomy. And again, that has to do with the location of the tumor. The lower the tumor is, the greater the likelihood they're going to need an APR done in a permanent colostomy.
Right. Even if they receive chemotherapy and radiation?
Yes, even still. Sometimes these tumors are just so low down, there's nothing you can do, but we can go down as low as we can go down, but you can't anastomose the bowel to the air outside the patient's body. So you have to have something normal below it in order to sew to. If they don't have anything normal below it, they're going to need a permanent colostomy. That's an APR.
All right, so let's shift our focus to the more advanced tumors in which chemotherapy and radiation is given before surgery. I know you're not a radiation oncologist, but you have a lot of experience.
Right.
How does that work, basically?
The patients will basically be seen in the office. We'll make the recommendations for the neoadjuvant therapy. We set them up with an appointment for a radiation oncologist and a medical oncologist. They will get concomitant therapy. It's combined therapy. And the reason we give this therapy is really for the benefits of the radiation more than anything. What the radiation will do is the radiation will shrink the tumor. The benefit of the chemotherapy is to sensitize the tumor to make the radiation more receptive, to make the tumor more receptive to receiving the radiation. So the way I like to think of it is, if you can think of like the chemotherapy pops up little antennas in the tumor, and those antennas receive the radiation better, and it makes the radiation more effective on the tumor bed itself. And I think that's a nice analogy of looking at it, and that's why it's effective therapy. So we will set these patients up for the therapy. They will go, they will work with both doctors, a medical oncologist and a radiation oncologist. They will work together. They will give the patient the therapy, and the therapy takes generally around 5 weeks to give, 5 to 6 weeks, somewhere around that area. And then after the 5 to 6 weeks have been completed, the patient will then be seen back in the surgeon's office, at which point we will then plan the operation. The operation is then planned for another 6 to 8 weeks after the completion of the radiation therapy. We don't operate right away. The reason we don't operate right away is because even though they're not getting radiation any longer, the ionizing effects of the radiation are still occurring within the tissues, and the tumor is still shrinking during a course of time afterwards. So the tumor still shrinks and it shrinks and it shrinks, and then eventually by 8 weeks it's maximized its benefit, and then we take them to surgery at that particular point in time.
Are the complications different when chemotherapy radiation is done before surgery?
Not particularly. I think I will say that every patient that does get chemoradiation before surgery will absolutely get a diverting stoma at the time of the surgery. If we're able to reconnect them, we do a diverting stoma. Sometimes you may make an argument if they didn't have the chemoradiation in advance and you were able to hook them back together, you may make an argument for not giving them a diverting stoma, although it's been our practice here to typically divert these patients temporarily because we think it's safer. But if you receive chemoradiation therapy, we definitely think you should have a diverting stoma because the tissues won't heal as well with radiation in the tissues after the surgery, when you do the surgery. So that is the downside to it, but it's a minimal downside to the operation. Obviously, patients don't want to have a stoma even for a temporizing measure, but I think it's a vital part of the recovery process for the patient as well.
I see. So typically those advanced patients will receive 4 months of chemotherapy after surgery as well.
Then after the surgery, we typically would recommend they get more chemotherapy. At this point, they're getting a different kind of chemotherapy. They're getting stronger chemotherapy. They're getting full dose chemotherapy for this. I like to think of the neoadjuvant therapy as like chemo light, if you will, and the chemotherapy afterwards is full-fledged chemotherapy. And we think that's beneficial because we believe that patients should be treated for 6 months with advanced rectal cancer in order to ensure themselves that the tumors are not going to recur.
I see. So if someone has had a bypassing procedure, you will put them back together after chemotherapy is done?
Yes, so then we wait till after the chemotherapy has been completed, and then we reverse the stomas for that.
I see. What about the scenario where sometimes a patient can have one lesion in the liver? How does that change your management?
It doesn't change a lot to us in the sense that we would still recommend pretty much the same thing that we would recommend if they have one lesion in the liver, because one lesion in the liver is still going to be resectable. So we would still probably offer them the same type of therapy. What we've done in some cases, though, if they have very advanced liver disease, multiple lesions, we would recommend upfront chemotherapy, full chemotherapy, before we did anything else, radiation or anything else at that point, because the most important thing there is to treat the systemic disease first rather than the local disease. So we would recommend those things in those particular cases, but for the most part, patients are receiving, as I mentioned, neoadjuvant therapy before their surgery.
What if the scenario where someone had advanced disease, we gave chemoradiation, and you do your surgery, and the tumor is all gone?
Yeah.
Would you recommend chemotherapy after that?
Still recommend chemotherapy after that. I think it's like buying a little bit of extra insurance policy, if you will, because we typically make recommendations based on the preoperative stage of the tumor, not the postoperative stage of the tumor. If the tumors went away, we're very pleased that they went away, but provided they can tolerate the chemotherapy, I think it's reasonable to give it to them. I see.
What do you tell patients in terms of odds of cure or recurrence?
Well, that depends on once again, it depends on the stage of the disease initially. The lower stage diseases, of course, do better than the more advanced stage of disease, but for the most part, patients do extremely well with this operation, and the recurrence rate should be under 10%, which is good, the local recurrence rate. As far as metastatic disease is concerned, it depends on the stage of the initial stage of the disease. Obviously, the more advanced stages of the disease have a lower survival rate over a period of time, but over 5 years. But you know, thankfully, most of the patients are done extremely well right now, and the chemotherapeutic agents that have been given now are much more improved, much improved from where they were before, and therefore patients seem to do a lot better now than they ever used to.
I see. I think more than anything, our patients look for hope from us. How do you give your patients hope when you first met them?
Well, I tell them that this is, you know, we go through the process. It's definitely is a process. We get to know the patients extremely well. We take care of them, not just for the time of the surgery. We see our patients for 5 years afterwards. We consider them cured at 5 years, and you know, I tell them that they're going to have a rough go of it for the first 9 months or so with all the surgeries, the chemotherapy, etc. They're going to have a pretty rough year. But after that, I tell them we're going to look back at this and have a good laugh at the whole thing at some point in time, and most of us do, and most of the patients do extremely well with it. So I think it's important to really, you know, discuss with them what to expect, and to make sure they're aware of the outcomes of this, and to make sure they're aware of the expectations, so that everyone's on the same page with this. But I think the patients, once they understand all of this, are usually very agreeable and amenable to going through the process.
Great, wonderful. Well, thank you so much. Really appreciate it.
Thank you.
Thank you for watching. We hope this has been educational for you as well.